So now it is my extreme pleasure to introduce Kirsten Oler. She received her BS degree in pharmacy from Ohio Northern University in Ada, Ohio, and a PharmD from University of Toledo. In 1997, she completed a pharmacy practice residency at the University of Illinois at Chicago, and in 98, a pediatric specialty residency at Children's Hospital in Columbus, Ohio. And afterwards, she focused her clinical practice primarily in the neonatal intensive care unit, most recently at the University of Illinois at Chicago, where she's also clinical assistant professor in the Department of Pharmacy Practice. In addition, she serves as the program director of the PGY2 Pediatric Pharmacy Residency and has served as faculty member for the ACCP updates since 2003. And so with that much experience, we know she's going to give us an excellent overview. Thank you.
Thanks, Lisa. Well, good morning, everyone. I will add my welcome to you. While I was happy to wake up in my own bed last year in Chicago, as Dr. Jacoby said, it was snowing there yesterday, so I'm more happy to be here in this weather. So we're starting with pediatrics, where we all began as children. Today, I don't have any conflicts of interest, except I'm a shameless promoter of pediatric pharmacy, so I think you should all be sitting in the room down the hall taking the PEDS course. But since you're here, we'll spend our 1 hour learning everything you need to know about pediatric pharmacy. So to do that, we're going to walk through some cases on neonatal sepsis, pediatric sepsis and meningitis, respiratory syncytial virus infection, otitis media, immunizations, pediatric seizure disorders, and attention deficit hyperactivity disorder. Now, of course, in real life, children experience a lot more diseases than those, and the patients are really more complicated in real life than we have time to discuss in this 1 hour period. But hopefully from these cases, you can kind of glean some of the important pharmacotherapeutic issues that go into decision making when we care for pediatric patients. As a reminder, we will use your audience response cards periodically through this session, so please have those readily available for your use. All right, we'll jump right in with case number 1. This is a neonate who was born prematurely at 36 weeks gestation, develops respiratory distress, hypotension, and mottling at 5 hours of life, has a witnessed seizure in the neonatal intensive care unit, at which time cultures are obtained and the results are currently pending. Of note, in the patient's history, the mother is colonized with group B streptococcus, but she did receive adequate intrapartum prophylaxis before delivery. So from this, we need to decide what the best empiric antibiotic regimen is for this neonate. So to start, we have to consider that this case, the signs and symptoms really do point towards neonatal sepsis. And in a pediatric patient, the diagnosis of rule-out sepsis often comes with an associated diagnosis of rule-out meningitis, especially when we have a presentation that includes such things as seizures. So with that in mind, as we're picking our antibiotic therapy, we want to choose agents that will penetrate the cerebral spinal fluid well, and we also want to make sure the doses are what are typically referred to as meningitic doses. So these are often higher than doses that are used for other indications. So with that in mind, we need to choose between vancomycin, ampicillin and gentamicin, ampicillin and ceftriaxone, or ceftazidime and gentamicin. As with any infectious disease, before we can figure out what our best empiric regimen is, we need to know what the most likely causative organisms are. And in the case of pediatric sepsis and meningitis, these organisms can vary by age. So if we consider this table, we see that our patient falls into this first category, 0 to 1 month of age. And in that category of neonatal sepsis, we can have 2 different types of sepsis. So there's early neonatal sepsis, which happens within the first 72 hours of life. And then there's late neonatal sepsis, which occurs after 72 hours of life. And that's important to consider because that also affects the most common pathogens that we're likely to observe in the patient. So with early neonatal sepsis, the organisms typically come from the maternal genitourinary tract. So we're looking at things like group B streptococcus, E. coli, and listeria, and potentially some viruses, most notably herpes. In late neonatal sepsis, those same organisms can be the cause, but if the patient has been hospitalized in that time, we also have to consider nosocomial pathogens. And in neonates, we're worried about coagulase-negative staphylococcus, gram-negative organisms, as well as fungus. So coming back to our patient, considering these antibiotics, vancomycin for an early presentation, again, we're not really concerned about coagulase-negative staphylococcus yet, so we wouldn't need vancomycin for that coverage. And this regimen doesn't provide the much-needed gram-negative coverage, so that would not be the best option. Ampicillin plus ceftriaxone potentially would cover the most common organisms, but then we have to think about side effects of these agents. And in neonates, the side effect profile of ceftriaxone is a little bit different than in older patients and adults. Ceftriaxone, because of its biliary elimination, can cause biliary sludging, which would decrease the elimination of indirect bilirubin, which can then cross the immature blood-brain barrier and cause kernicterus. So ceftriaxone in a neonate typically is not a good option. Ceftazidime and gentamicin, again here we're lacking the important coverage of listeria and group B streptococcus. Even though the mother received intrapartum prophylaxis because she was colonized for group B streptococcus, and that intervention has been shown to decrease the number of cases of GBS neonatal sepsis, it is still recommended that our empiric regimen account for that organism and cover GBS. So ceftazidime and gentamicin, for that reason, would not be a very good choice. Additionally, for early neonatal sepsis, we really don't need double coverage for gram-negative organisms, so this is a little bit overkill. That leaves us with ampicillin and gentamicin as the best option here. Again, remember, we would want to give this in doses adequate to penetrate the meninges. And to do that, we have to consider some pharmacokinetic differences that we see in the neonatal population compared to older children and adults. So those changes include such things as higher volume of distribution for water-soluble drugs. So typically things like aminoglycosides, we need to administer higher milligram per kilogram doses than we would in the older children or adults. And additionally, there's typically a slower clearance of renally eliminated drugs, especially in preterm babies. So again, our dosing interval would be extended for these types of drugs in neonates as compared to older children and adults. Some of you might be wondering about the regimen ampicillin and cefotaxime. This is often, or at least sometimes, seen in neonatal intensive care units to treat neonatal sepsis. Because of concerns with resistance with routine third-generation cephalosporin use, and because there is some evidence that that regimen is associated with worse outcomes and increased mortality as compared to ampicillin and gentamicin, the regimen of ampicillin and cefotaxime really isn't recommended for empiric coverage of neonatal sepsis. If, on the other hand, we have organisms that grow that warrant those agents, then cefotaxime might be a reasonable choice in this population. So continuing with this patient, our preliminary culture results are now available, and they reveal gram-negative rods in the cerebral spinal fluid. So we need to determine what our recommendation is regarding antibiotic prophylaxis in such a case. So should we give this prophylaxis to the patient's 5-month-old stepsister who might be at high risk because she's not yet fully immunized at that age? Should the patient receive rifampin prophylaxis to eliminate nasal carriage of the organism? Is antibiotic prophylaxis not indicated, or should all close contacts receive antibiotic prophylaxis? So, first to answer this question, we need to understand what is the purpose of this prophylaxis. And the primary purpose is to prevent bacterial meningitis caused by the spread of Haemophilus influenza and Neisseria meningitidis. It's been shown to benefit most a specific high-risk population, and that is household contacts of the index case, any nursery or child care contacts, and anyone who has been in direct contact with the patient's secretions. In those cases, the drug of choice for prophylaxis is rifampin. So based on our patient's age, these gram-negative rods are most likely to be E. coli rather than Haemophilus or Neisseria meningitidis. So in this case, antibiotic prophylaxis would not be indicated. If this patient fell into the age group of 3 months and older, that's where we start seeing Haemophilus influenza and Neisseria meningitidis more commonly. And in the case of a patient of that age, then prophylaxis of all close contacts with rifampin would be indicated regardless of those people's age or their immunization status. Case 3 is that of an older child. So now we have a 6-month-old boy who presents to the emergency department with fever, altered mental status, and petechiae. There's no history of trauma, and his toxicology screen is negative. His laboratory results indicate an elevated white blood cell count with a left shift. Cultures, again, have been sent, but the results are pending. Patient has no known drug allergies, so we need to determine, once again, what is the best empiric antibiotic regimen for this patient who presents, again, with signs and symptoms consistent with sepsis and possible meningitis. So ampicillin and gentamicin are, again, options: cefuroxime, ceftriaxone plus vancomycin, or rifampin. So if we revisit this table of most likely organisms, now our patient falls into this broad age range of 3 months to 12 years. And this, again, as I mentioned, is where we start seeing Haemophilus influenza, Neisseria meningitidis, and Streptococcus pneumoniae. Haemophilus influenza is not as common as it used to be in this population because of routine use of the Haemophilus vaccine. But keep in mind, we are seeing more cases again in the unvaccinated children. So if we go back to our options, while ampicillin and gentamicin was the regimen of choice in neonatal sepsis, it will not provide good coverage in this older patient. Cefuroxime potentially will cover some of those organisms we're concerned about, but remember, the presentation seems to be consistent with possible meningitis, so we want something to penetrate the CSF, which cefuroxime does not reliably do. Rifampin, as I mentioned, is the drug of choice for prophylaxis when we are concerned about Haemophilus influenza and Neisseria meningitidis, but should not be used alone as a treatment option. So for this patient, ceftriaxone and vancomycin would be the best option. Depending on regional susceptibility patterns, ceftriaxone alone might also be a reasonable option. If you are in an area where there's a high occurrence of resistant Streptococcus pneumoniae, vancomycin is recommended to be added empirically. And then, of course, once the organism susceptibility and identification is available, then we would tailor the regimen accordingly. All right, we'll move to respiratory syncytial virus now. So here we are screening babies in the current respiratory syncytial virus season for risk factors associated with the development of severe RSV infection. And based on those risk factors, we need to determine which patient would be best to receive Palivizumab for RSV prophylaxis. So we have 4 patients to choose from. Patient A was born prematurely, is now 18 months old, has a history of chronic lung disease, but has not required oxygen or medications for that indication in the last 8 months. Patient B, also born prematurely, is now 5 months old, also has chronic lung disease requiring no treatment. Patient C, born prematurely at 31 weeks, does not have chronic lung disease. And patient D is 10 months old, was born with a congenital heart defect that has been surgically repaired. So in order to determine the appropriateness of Palivizumab prophylaxis in these different scenarios, we need to understand what the risk factors are for severe RSV infection. And the number 1 risk factor is premature birth. Other risk factors include chronic lung disease, also known as bronchopulmonary dysplasia. Congenital heart diseases put patients at risk for severe infection, as does immunodeficiency, airway abnormalities, and some other risk factors like low socioeconomic class, passive exposure to smoke, daycare attendance, and young siblings. Considering these risk factors, the American Academy of Pediatrics has put forth recommendations for which children would benefit most from Palivizumab prophylaxis. And these guidelines were recently updated in 2014 and really changed significantly at that time. So now the guidelines are based on the patient's gestational age, as well as their age at the time of the start of RSV season, and other risk factors and criteria that might be present. So the RSV season is kind of defined based on the geographic location. So timing depends on where you are. So for example, in the Midwest, in Chicago where I practice, the season is typically November to March. In warmer climates, sometimes the season peaks a little sooner than that. So it's important to know where you are and where the season would begin. But during that season, then, the patient would receive 5 monthly doses of Palivizumab, which has been shown to reduce the risk of hospitalizations for severe RSV infection. So, given that, the American Academy of Pediatrics recommends anybody born prematurely less than 29 weeks gestation would be a good candidate for Palivizumab prophylaxis. They don't need to have any other risk factors except to be less than 12 months of age at the start of RSV season. Between that gestational age, so between 29 and 32 weeks gestation, again, if the patient is less than 12 months of age at the start of the season, they need an additional risk factor, that being chronic lung disease requiring oxygen therapy for at least the first 28 days of life. So this is a change from the previous guideline where those patients also just automatically qualified based on prematurity. Those patients born less than 32 weeks gestation could also be considered for a second course of Palivizumab for a second season if they are less than 24 months of age at the start of RSV season and their chronic lung disease requires drug therapy or medical therapy within the last 6 months. So within 6 months of starting the RSV season, they may also be appropriate candidates for Palivizumab prophylaxis. The remaining risk factors are not based on gestational age, but based on other risk factors. So anyone less than 12 months of age who has a congenital heart defect that requires treatment for congestive heart failure and will need to be surgically repaired would be an appropriate candidate. Any infant with moderate to severe pulmonary hypertension, any infant with congenital airway abnormalities or neuromuscular disease, and then finally, any infant less than 24 months of age at the start of RSV season who is profoundly immunocompromised could benefit from RSV prophylaxis. So if we come back to our patients considering those risk factors, patient A was born prematurely less than 29 weeks, but now he's outside that 12-month window, so would not automatically qualify. So he needs to have a history of chronic lung disease that's been treated medically, either with oxygen, bronchodilators, diuretics, maybe inhaled corticosteroids, within 6 months of the start of RSV season. So this patient does not meet those qualifications, so would not qualify for Palivizumab prophylaxis for the current RSV season. Patient B, also born prematurely, but is only 5 months old, so they meet the criteria based solely on the fact that they were born prematurely. They don't need to have other risk factors to be a good candidate for Palivizumab prophylaxis. Patient C is born at 31 weeks, so he's in that 29 to 32 week range where he needs to have the risk factor of chronic lung disease, and he does not. So he would not be a good candidate. Even though he's attending daycare, that used to be a criteria in the old guidelines and no longer is. So again, patient C would not meet the criteria for Palivizumab prophylaxis. And finally, patient D does have a congenital heart defect, but it has already been surgically repaired, so he is not at as high of risk as a patient would be if it was unrepaired. So would not be the best option either. All right, case 5, we'll go to your audience response cards. Here we have an 18-month-old with a history of premature birth and chronic lung disease. He's admitted to the pediatric intensive care unit with respiratory distress requiring intubation. He has a fever, has had a 3-day history of cold-like symptoms. A nasal swab is positive for respiratory syncytial virus. So now we need to determine what the best treatment option is. So previously we were looking at prophylaxis of RSV, and now we're looking at treatment for RSV. So would the best intervention be Palivizumab, dexamethasone, cefuroxime, or intravenous fluid and supportive care? What does everyone think? Good, I see a sea of yellow. That is the right answer. Palivizumab, again, the drug of choice for prophylaxis, but does not have a proven role for treating RSV. Corticosteroids have not been shown to decrease length of stay or morbidity associated with severe RSV infection, so they are not routinely recommended for this indication. Cefuroxime and any other antibiotic therapy would not be recommended empirically. While patients with RSV infection can have secondary bacterial infections, that's fairly rare, and so you treat it if it happens. We don't typically begin empiric therapy. So, as you all know, intravenous fluid and supportive care would be the best option. All right, we'll move on to otitis media. Here we have a case of a 5-month-old infant, otherwise healthy, born at term, has been treated for her first episode of otitis media and received amoxicillin 45 milligrams per kilogram per day, is being seen in follow-up by the pediatrician, and on physical exam still has some fullness in her middle ear and a cloudy tympanic membrane, but she's found to be afebrile. Her parents report that she's eating well. So what would be our recommendation for treatment at this time? Are no other antibiotics warranted? Should she receive high-dose amoxicillin, decongestants and antihistamines, or azithromycin at this point? So again, we need to know our common organisms. For otitis media, viruses are by far the most common cause. We can also see Streptococcus pneumoniae, non-typable Haemophilus influenza, and Moraxella catarrhalis. Interestingly enough, regardless of what the pathogen is, more than 70% of cases will self-resolve without any kind of treatment. And unlike a lot of infectious diseases, we don't typically have a culture to guide our therapy. So we treat otitis media empirically based on this list of expected common pathogens. So because of the high clinical resolution rate and the fact that viruses are the most common causative organism, the American Academy of Pediatrics now recommends that immediate antibiotics only be prescribed if there's a bulging tympanic membrane or otorrhea. Otherwise, the AAP recommends delaying antibiotics if there's no bulging tympanic membrane, no severe systemic symptoms, and the patient is older than 2 years of age. In those cases, only if the fever or otalgia persist longer than 48 to 72 hours would antibiotics be prescribed. And this delayed antibiotic prescribing is now also recommended down to 6 months of age if those patients have mild symptoms and their diagnosis of otitis media is unilateral as opposed to bilateral. In these patients, we would just use analgesics. Those have been found to be more effective in treating the ear pain than antibiotics in the first 24 hours. And then again, as I mentioned, the antibiotics would only be prescribed if symptoms persist beyond 48 to 72 hours. Another important thing to recognize with treating otitis media is even after treatment, it's common to have a persistence of middle ear fluid. And that persistence, if it's not associated with systemic signs and symptoms, is termed otitis media with effusion. And those patients also are recommended to fall into the watch and wait category. So a more detailed treatment algorithm for otitis media can be found in your online workbook, but those are the general principles for approaching a patient with otitis media. So in the case of this 5-month-old, she was treated with low-dose amoxicillin, which is not a recommended regimen anymore, but she seems to have recovered from her otitis media. She doesn't have any systemic symptoms. So at this point, her diagnosis is likely otitis media with effusion, and antibiotics would not be recommended. If she did have systemic symptoms that were severe enough to receive a diagnosis of actual acute otitis media, then in that case, high-dose amoxicillin would be the drug of choice. Because she's less than 6 months old, we would not use the watch and wait approach for this patient. Azithromycin, although we see it a lot, the pediatricians love it, it's really not a good choice for otitis media. More than 70% of strains of Streptococcus pneumoniae are reported resistant to azithromycin. This drug also does not have good coverage for Haemophilus influenza, so it's really not the best option to go to for otitis media. Decongestants and antihistamines have not been shown to improve the symptoms or shorten the course of otitis media, so again, are not routinely recommended for its management. All right, let's go with the audience response cards again. Here we have an older patient, a 4-year-old boy, who's now been diagnosed with 4 cases of otitis media in a 12-month time span. He has no evidence of hearing loss or delayed language skills, and so we need to determine what would be the best intervention for him at this time. Should he receive long-term antibiotic prophylaxis? Are tympanostomy tubes best at this point? Should he receive high-dose amoxicillin and immunizations, or are no antibiotics warranted at this time? What do you think? All right, so I see a lot of different options, which is good because that's what I was thinking would happen. So what's important to recognize here is this patient's diagnosis is now recurrent otitis media. And that's defined as 3 or more cases of otitis media in a 6-month period or 4 episodes in a year. So when a patient has recurrent otitis media, the delayed antibiotic prescribing, the watch and wait, is no longer recommended, even if the patient meets the age criteria, okay? Historically, we would use long-term antibiotic prophylaxis in these types of patients, but more recently, with concerns of development of antimicrobial resistance and some evidence that this practice really only decreases episodes of otitis media by about 1 case a year, this practice has fallen out of favor. Tympanostomy tubes, while we as pharmacists don't raise our hand and say, hey, put in tubes, I think it's good to know what the indication for some other options are. And in the case of tympanostomy tubes, although they seem to be seen frequently, they're recommended and most beneficial in patients who have failed aggressive antibiotic therapy, continue to have profound effusions that are causing hearing loss. So those are the patients that are most likely to benefit from tubes. So in the case of this patient, as long as each individual episode of otitis media continues to respond to antibiotic therapy, high-dose amoxicillin would still be the treatment of choice. And then, of course, we want to make sure that he's up to date with all his age-appropriate vaccines, because things like streptococcus and viruses are common causes for otitis media. All right, we'll wrap up our discussion of pediatric infectious diseases with a couple of cases related to immunizations. Here in case 8, we have a 1-year-old boy with a history of Kawasaki disease that was treated 4 months ago with intravenous immune globulin. He's at a well child visit where he's found to be due for MMR and varicella based on his age. Of note in his medical history, besides the Kawasaki disease, he has a number of food allergies, including eggs. And his mother has several concerns about immunizations. So we're asked, what would be the best justification to defer antibiotics or vaccines in this patient? Would it be an association with MMR and autism? A concern for allergic reactions with MMR related to patients with egg allergy? Is it that many concurrent vaccines can overload the immune system, or that decreased vaccine efficacy can happen because of previous IVIG administration? So there are a lot of myths and misconceptions about vaccinations that often lead to missed opportunities for vaccination in children. And as pharmacists, it's very important that we understand these and understand the true contraindications. Oftentimes, for example, in my practice, I spend a lot of time with parents talking to them about their concerns with vaccines because, as you know, there's a lot of information out there, both pro and con for these things. So there are some true contraindications, but as you see, the list is fairly short. True contraindications include a known anaphylactic reaction to the vaccine you're planning to administer, an acute moderate to severe febrile illness, immunodeficiency, pregnancy, or a recent IVIG exposure is a contraindication if we're planning to give live vaccines, not for inactive vaccines. And a history of encephalopathy within 7 days of receiving a previous tetanus or diphtheria, tetanus, and acellular pertussis dose. So those are really the only true contraindications to giving a vaccine. There are a lot of misconceptions that are thought to be contraindications. So things like mild acute illness. So a fever is not necessarily a contraindication unless it's associated with moderate to severe illness. Likewise, antibiotic administration is not a contraindication as long as it's for a mild infectious disease. There are a lot of concerns about vaccines and autism, but as most of you know, the study that brought that to light has since been retracted because the investigator was found to have falsified all of that data. And subsequently, the CDC has published a study that included over 1,000 patients and showed no association between various vaccines and autism. So these are important things to be aware of so we can talk to our parents and make sure that children get vaccinated appropriately. Another consideration for potentially deferring vaccines is this notion of special populations. And we'll come back to this list again, but for this case, I just want to draw your attention to patients who recently received intravenous immune globulin. So here, the recommendations for deferring vaccines relate, again, only to live vaccines, not to inactive vaccines. And the recommendation for what to do really depends on what the indication for the IVIG was and what the dose was. I don't anticipate that everybody knows. I don't know all of those details. If you're interested in that, I would refer you to the American Academy of Pediatrics Red Book, which is a great reference for all things pediatric infectious disease, and they go into a lot more detail about vaccines. But knowing that IVIG can interfere with live vaccines is an important concept. So if we come back to our patient, as I mentioned, a lot of parents have concerns about vaccines and autism because of what's out there in the press, but this is not a reason to defer vaccines. Likewise, there's a prevalent thought that multiple vaccines will overwhelm the immune system in young children. In fact, it's been shown that daily life exposes them to more antigens than the vaccine schedule does. And so those vaccines, that's not a founded concern. MMR is grown in chick embryo tissue, but a allergy to eggs is not a contraindication with that product. So here, potentially a reason to defer immunizations is because the patient received IVIG and is due for live vaccines, the MMR and the varicella. Again, yeah, it depends on what would recent be. Again, it depends on the indication and the dose, but it's typically a certain number of months, 4 to 6 months, and then the delay is then a few months. It's not like delay it for their lifetime or anything like that. Case 9 considers 4 different patients who are being seen by their pediatrician for well child checkups, and based on the routine immunization schedule are due for some sort of vaccination. Again, we're asked for justification to defer immunizations in any of these patients. So we have patient A, who is a 12-month-old who recently completed chemotherapy for a cycle of chemotherapy for ALL. B is a 6-month-old girl who's on amoxicillin for otitis media. C is a 12-month-old HIV-positive boy with a CD4 count above 1,000. And D is a 12-year-old girl completing a steroid burst for an asthma exacerbation. So I'll show you the immunization schedule, again, not because I think everybody needs to know this intimately, but because it's important to recognize how complicated it is, and that's one of the barriers to routine immunization is people don't know when or what needs to be given. So if we look at this schedule, we have a 6-month-old who would be due for hepatitis B, diphtheria, tetanus, and pertussis, and the pneumococcal conjugate vaccine. We have a couple of 12-month-olds who would be due for MMR and varicella, as well as potentially some other vaccines, and then a 12-year-old who would be due for human papillomavirus vaccine, meningococcal vaccine, and the tetanus pertussis booster. So again, different ages, we're looking at different vaccines that are due. So if we come back to our list of special populations, a number of our patients fit these categories. It's important to know that for immunocompromised children, we should not be giving live vaccines because of the risk of then acquiring vaccine-associated disease. For patients receiving corticosteroids, again, the recommendations for deferral of vaccines depends on the dose of steroid and the duration. In general, if it's a low dose, so less than about 2 milligrams per kilogram per day of prednisone equivalent, then it's okay to vaccinate. If it's higher than this dose, but given for a short period of time, typically less than 14 days, again, it's okay to administer on schedule all age-appropriate vaccines. So if the vaccine dose is higher than 2 milligrams per kilogram per day, if the If the corticosteroid dose is higher than 2 milligrams per kilogram per day, or the duration is longer than 14 days, then for those patients we would recommend deferring live vaccines again. And typically that deferral period is 1 month after the end of the steroid course. And then HIV-infected children, again, the recommendations depend on their degree of immunocompromise. If they're not symptomatic of their disease, if they do not have evidence of severe immunocompromise, then patients with HIV should receive all age-appropriate vaccines, including the live vaccines. So based on the age-appropriate vaccines that our patients are due for, patient A would be the most appropriate in which to defer vaccines because he is likely to be immunocompromised from his chemotherapy. Our 6-month-old girl, here again, otitis media, antibiotics, not necessarily a contraindication because it's a mild infection. Our patient with HIV is not severely immunocompromised, so can receive vaccines. And the patient receiving prednisone is on a low-dose short course. So again, not a reason to defer. So all of these patients could have a reason to defer, but given this scenario, they don't. All right, we'll leave infectious diseases, move on to pediatric seizure disorders. So here we have a 14-year-old girl. Is moderately obese, complains of an erythematous pruritic rash. She was started on oxcarbazepine 3 weeks ago for partial or focal seizures. And outside of that, her past medical history is relatively insignificant. Socially, she does admit to being sexually active with a male partner, and they are inconsistent with their contraceptive use. So we're asked, what's our best intervention for her anti-epileptic therapy at this point? Should we change to carbamazepine, change to levetiracetam, change to valproic acid, or is no change necessary? So just like with adults with seizure disorders, our choice of anti-epileptic therapy depends on the type of seizure we're treating. And in this patient, we have focal or partial seizures. We can see that drugs of choice are some of the options we're given in this question, valproic acid, carbamazepine, and then there are a lot of alternatives, including oxcarbazepine, which is a drug she's on, and levetiracetam, which is one of our alternative options. So before we switch, if her symptoms are well controlled, we really need to know, is this rash likely to be associated with her anti-epileptic therapy or not? So this slide is a summary of some of the most common side effects seen with anti-epileptic therapy. There's, again, a more detailed table in your electronic workbook. But we can see that rash is common with anti-epileptic therapy. And unfortunately, with rash, there's no reliable way to predict if that will progress to something more severe like Stevens-Johnson syndrome. So when rash appears, generally we'll consider changing the anti-epileptic therapy. So we can see oxcarbazepine, which she's on, is associated with rash. Carbamazepine, one of our alternative options, actually has a higher incidence of rash, and there is cross-sensitivity between those agents. Levetiracetam is not typically associated with rash, nor is valproic acid. Valproic acid has some other side effects we want to consider. It can cause weight gain, it can cause menstrual irregularities, and so keeping in mind these types of cosmetic side effects is important, especially when we're treating teenage girls. Adherence in teenagers is difficult anyway, and then things like cosmetic side effects make them much less likely to take a drug. In addition, valproic acid is a known teratogen, so given this patient's social history, that would be a potential concern here. So if we come back to our options, changing therapy should occur because of this rash and we're not sure if it's going to progress. And I would say that levetiracetam, of the choices we're given, is the best option. As I mentioned, side effects need to be considered in this patient population. Adherence is really tricky in teenagers, and I would be very concerned about the risk of teratogenicity here. Because the problem with most teratogens is they exhibit their effects early on in the pregnancy, oftentimes before anybody even knows they're pregnant, and so you really want to avoid them before the pregnancy happens, because after the pregnancy happens, the damage is potentially already done. All right, good. We'll wrap up with 2 cases related to attention deficit hyperactivity disorder. So here we have a 9-year-old boy who's newly diagnosed with ADHD. He's having disruptive symptoms both at home and at school. Diagnosis of ADHD is another one of those relatively controversial things within pediatrics. It's a disease that absolutely affects negatively patients that have it, and so we are going to approach this as if he's clearly diagnosed, the proper diagnosis was made, he has ADHD, so what would be the best initial regimen for this patient? So should he receive methylphenidate OROS, which is brand name Concerta, once a day? Should he receive methylphenidate immediate release, which is Ritalin, twice a day? Guanfacine at bedtime, or D-methylphenidate, which is brand name Focalin, twice a day. So when we consider treatment for ADHD, it can be divided into 2 major categories. There are the stimulants and the non-stimulants. And of the stimulants, we can have methylphenidate-containing products as well as amphetamine-containing products. The stimulants are the drugs of choice, so we'll start there. Again, these next few slides are a summary of more detailed tables that are in your electronic workbook. But if we start with the stimulants and the methylphenidate-containing products, the major difference between these products really is their duration of effect. And so we can have short-acting agents, and here I'm going to use the brand names because the generic names are so very similar. So we can have short-acting agents like Ritalin or Focalin, intermediate-acting agents like the Methylphenidate IR or Ritalin SR, and then long-acting agents like Concerta. Regardless of their duration, their side effect profiles are very similar, and they're what you might expect from a stimulant. So insomnia, headache, loss of appetite. These agents can also worsen tic disorders, and that's important because tics can be comorbid in children with ADHD in up to 20, depending on what you read, even 90% of all cases. So that's an important consideration here. The other stimulant products are the amphetamine-containing products, and again, the major difference is really their duration of effect. So you have Adderall, the shorter acting, and then Adderall XR, the longer acting product. These side effects, also what you would expect from stimulants, so again, the insomnia, loss of appetite, nervousness, worsening tics, and also potentially worsening hypertension. The amphetamine products also have a potential association with sudden cardiac death, especially in children with underlying structural heart disease. So although there's no proven causal relationship here, the American Academy of Pediatrics does recommend a targeted cardiac history in the child before starting an amphetamine product. They don't recommend routine EKGs and echocardiograms unless then that history and physical point towards likely structural heart disease. So basically you just screen them based on history and physical first, and then if that brings up a red flag, then further testing to prove if they do have structural heart disease or not would be warranted. As I mentioned, the stimulants are the drugs of choice. And just because a patient fails one stimulant doesn't mean that they would fail another. In fact, most children, about 80%, will respond to one stimulant if we're able to optimize the dose and they can tolerate the side effects. So typically this is where we start. And then if the child fails at least 2 stimulants, then we start thinking about non-stimulant options. So here we have a couple of choices. Atomoxetine, brand name Strattera, does not have the typical stimulant side effects, also does not exacerbate tics, so that might be an important consideration. There is a potential association with liver injury, and there is a black box warning regarding increased suicide risk in children and adolescents. So that's an important consideration when we're choosing an agent. Clonidine and guanfacine, the alpha agonists. Clonidine has been shown to be more effective typically on hyperactivity symptoms than inattention. It also can lessen tics, so even though stimulants can worsen tics, we don't usually not use them first, but if we do use them and the stimulant seems to worsen the tic disorder, then we would think about switching to one of these agents that does not affect the tic disorder. Clonidine, again, does not have the typical stimulant side effects. Instead, it causes sedation. The difference with guanfacine is it has reportedly less sedation than clonidine, and it also comes in an extended release product, so it can have a longer duration of symptom control. So if we return to our 9-year-old boy, he's having symptoms that are disruptive at home and at school. So that would kind of point us to the fact that a shorter acting agent may not be effective in controlling his symptoms. So things like methylphenidate IR and dexmethylphenidate probably would not provide him with adequate symptom control. Dexmethylphenidate also has been marketed as having less side effects than the immediate release methylphenidate product, but hasn't really been shown to be a cost beneficial option. It's more expensive. Guanfacine does have, as I mentioned, an extended release product, so it could provide symptom control over a longer period of the day. However, we generally reserve that. Again, it's a non-stimulant, so we generally reserve that for children who don't respond to stimulant therapy. Or if they have worsening of tics on stimulant therapy. So in this case, ideally, something like methylphenidate OROS Concerta would be a good choice because it's long-acting. The other benefit is that means you don't have to give a dose at school, which again can affect adherence. One, because again, kids don't like to take medications when their friends don't. That's not as much of a stigma for us old people because a lot of people are on medications, but for kids it is, and it's a deterrent. And so that adherence, arranging it with the school, can be complicated. There is some thought by some prescribers that you need to titrate up the dose with an immediate release product first and then convert to a long-acting. That is not true, so we can start with a long-acting. The one problem you encounter sometimes with starting with a long-acting agent is a lot of insurance companies will require the child to fail an immediate release product first before they'll approve and pay for a long-acting product. But in the ideal world, in a patient like this who has a long duration of symptoms in the day, a longer-acting product would be a good option. Our last case is the same patient. He's now started on methylphenidate OROS Concerta. His symptoms are well controlled, but now he's complaining of insomnia. So how should we best modify his regimen? Should we recommend the Concerta be given later in the day? Should we change to methylphenidate modified release? change to a methylphenidate patch, or change to atomoxetine at bedtime. What does everyone think? Okay, some different options here. So again, with this kind of question, we kind of have to choose what's the best option that we have presented to us. So by giving Concerta later in the day, that actually potentially would worsen insomnia, and most of you recognize that. Potentially, if we could give Concerta earlier in the day, allow serum concentrations to fall later in the day so that they're not affecting bedtime, that might be an option, but we're not given that choice. Changing to methylphenidate modified release, so a shorter acting agent, might help with decreasing the insomnia symptoms, but it also might affect the duration of symptom control. And again, with this patient having symptoms at home and later in the day as well as at school, that might lead to more poorly controlled symptoms. The other interesting thing to think about with that is if you are not providing adequate coverage for the symptoms, so they don't have coverage long enough in the day, and their ADHD symptoms recur later in the day, that could actually be the cause of the insomnia as well. So even though we are thinking we're going to shorten the duration of effect of the drug, and so they won't have insomnia later in the day, and children who have symptoms later in the day, if those resurface because we're not providing a long enough acting agent, then they can still have sleep disorders. Changing to atomoxetine might be an option. The response rate to atomoxetine is lower typically than with methylphenidate OROS. So here we have a patient who's well controlled on a stimulant. So a better option might be to try to figure out how to modify and optimize that stimulant regimen. Additionally, when we start atomoxetine, there's a delayed response, so it often takes somewhere between 2 and 4 weeks to see a response. So again, we go from a well-controlled patient, and if we switch drugs, there's a potential period for poor control until atomoxetine takes effect. So in the case of the options that we're given here, potentially switching to a methylphenidate patch would be a better option. This provides some flexibility in terms of duration of effect because the timing of how long the patient wears the patch dictates how long the effect is. So for example, if they wear the patch for 9 hours, they typically have symptom control for about 12 hours. So they can kind of experiment with how long they wear the patch to cover their symptoms and then hopefully decrease the insomnia later in the day. Other important counseling points here are just regular sleep hygiene pointers. So, decrease the TV and all the electronics before bedtime, have them do some quiet things like reading and that kind of thing can also help. So don't forget that some of the non-pharmacologic interventions are very important as well, especially when we have a patient whose symptoms are very well controlled. We might want to try to find some other non-pharmacologic options.